And Dr. Kapoor, for the patients that are sitting, is a uro-oncologist and professor of surgery and oncology at McMaster University at St. Joseph Hospital in Hamilton, Ontario. Dr. Kapoor is also a board member of our Kidney Cancer Canada and the chair of the KCRNC. And he is currently the head of clinical trials group at McMaster University, McMaster Institute of Urology. And Dr. Christian Colemannsberger has joined us here from British Columbia. So your days hasn't been going too long yet. You're a few hours behind us. And he is a medical oncologist at the British Columbia Cancer Agency at the Vancouver Cancer Centre. And Dr. Lalani has joined us. He is an assistant professor at McMaster University and a medical oncologist at the Juravinski Cancer Centre in Hamilton, Ontario. Thank you so much for coming. And I'm shuffling my notes here quickly, as you can tell. Dr. Wilson Miller, I've lost your sheet, Dr. Miller. I apologize, but I know that you're a James McGill professor. Is that an award winner?
I'm a professor of medicine oncology at McGill and work at the Siegel Cancer Center in basic and translational and clinical research.
Thank you so much. I apologize for losing your sheet. And gentlemen, I think we're going to have a free-flowing conversation. I'll let you direct Dr. Kapoor on clinical trials. This is an opportunity to talk briefly about clinical trials and anything that might be new coming up that might be of interest to our patients, and also standard of care. I know there's a lot of questions. I'm sure there'll be a lot of questions at the end, but I'll let you get started. Thank you.
Fantastic. Well, welcome. We have a great panel here. We have Dr. Colemannsberger from Vancouver, who's now, as I understand, hanging out in Montreal today. Is that right?
That is correct.
Excellent. So that's why the weather is so nice.
Because it's a lot warmer in Montreal than in Vancouver.
Of course, of course. And we have my good colleague, Dr. Lalani, who is an up-and-coming medical oncology star. We're very proud of everything he's accomplished and going to accomplish, and so we look forward to your input. And Dr. Miller, who is a professor emeritus at McGill University. So welcome, Dr. Miller, as well. So I think we'll just start off.
I haven't quite retired yet.
Oh, sorry, professor. Sorry, just full professor. That's all. Well, welcome, Dr. Miller. So we're going to talk about, first of all, what standard of care is. I think many in the audience want to know what's been happening in treating metastatic RCC. A lot of great new innovations and new drug therapies, new molecules in the last year or so. So I think we'll start off with Christian to just describe a patient that may come forth with metastatic kidney cancer. What would be the approach currently?
Well, the approach currently, the first question one needs to ask there is in what kind of prognostic profile a patient falls. As you know, we are using a classification to look at different factors and then determine which one of the groups the patient falls, and then that to a certain extent dictates what the options are. But I would say that the majority of patients these days are eligible for a combination therapy, in contrast to about 3 or 4 years ago, when usually the standard treatment was a pill treatment and a single agent treatment. In nowadays, immunotherapy has really taken over, and the majority of patients are eligible for that, and that is usually a combination regimen. And I think that is really the big change we've seen over the last 2 or 3 years, that we really moved into this immunotherapy world where we where we are giving drugs that stimulate the patient's own immune system to fight the cancer.
Wonderful. So you touched on when they come through to your clinic, the first thing you do is look at their risk stratification. I think for the sake of the audience, Dr. Lalani will go through that, I guess. What are the so-called IMDC criteria, Dr. Lalani?
Yeah, no, it's a great question, and as Dr. Colemannsberger mentioned, is something that's still top of mind. So there's a mix of really some clinical and what we call lab or blood test values. I think some important ones are to understand when the patient is with you, how is the patient doing? So we have various performance scores, the ECOG performance status for the IMDC score, specifically Karnofsky performance score. But it's a way to understand from the history from a physician and a patient how well the patient is doing. And so that's an important score. Obviously, if the performance status for the patient is not that well, and there's a cutoff for that, that would count as a score or a point when we tally up this total. The other thing we try and look at is something called the time from diagnosis to needing treatment. And to really simplify it, essentially, it's trying to understand from a time that a patient is diagnosed with kidney cancer, how quickly are they presenting with a systemic disease or needing systemic therapy. So, for example, someone may come to a clinic and have a localized kidney cancer, and that is surgically removed and perhaps never recurs, or if it recurs, occurs many years later, let's say 5 years later. Whereas there might be a patient who shows up, unfortunately, with a brand new stage 4 diagnosis. Again, the time from the diagnosis to needing systemic therapy would then be within 1 year. So that would be another point. We look at a few other blood tests that are helpful in kidney cancer. One is your hemoglobin level. If that is considered low, below your lab limit of normal, that would be a point. Part of your white blood cell count is your neutrophil count. This often is helpful to fight infections, particularly bacterial infections. And so if that is high, that's felt to be kind of working against or at least suggestive of a more aggressive type of disease. Same thing with a platelet count, just suggesting more underlying inflammation. And so when we put that together with a high calcium level, which we know a lot of cancers can have, we try and put these scores together. And so if some folks will have none of these scores or none of these points, that's considered a good prognostic risk or good risk. Some patients may have 1 or 2, and that's considered intermediate risk. And if patients have 3 or more, that would be considered more of a poor risk group. And the reason, as Dr. Kommensberger mentioned, that's really helpful is to try and have a conversation about big picture ballpark prognosis. And then also some of our treatments do depend on what your score is. And I'm sure we'll talk more about that.
Nice. That's a great summary. Yeah. So you have those 6 scores, and when somebody comes in, we look at those 6 criteria to look at a risk stratification. So Dr. Miller, I guess one of the things we could talk about, your video looks very static. I'm not sure if you're able to see us or not, or just on video.
I see and hear perfectly. I'm not sure why my camera is not tracking.
Okay, well, you look very handsome. The somebody comes in with a metastatic kidney cancer, and in the old days we used to do what's called a nephrectomy, where we would take the kidney out surgically, and that would help the patient in the old days to in terms of their longevity. But that's been more controversial now. What are your thoughts about somebody that comes in, a patient comes in with their metastatic kidney cancer, and whether we should take their kidney out or not where the cancer is?
Yeah, so there has been a recent randomized trial which suggests that this is not necessary and maybe not even a good idea in many cases. I think if there's not a specific reason, such as bleeding or pain or other local problems, it would not be the first thing I would think of. As clinical as the armamentarium of systemic therapy gets better, this is another reason I think we go to that first. As I'm sure we'll talk about, there are dual immunotherapy regimen. There is a dual immunotherapy regimen. There are immunotherapy plus targeted therapy regimens, of which 3 have been evaluated, and there may be more coming. And so I think most of us favor getting started with that and leaving the idea of nephrectomy to perhaps the somewhat distant future. If the patient has a great response everywhere else, then the surgeons will come back and suggest maybe they should do something.
That's a bit provocative. I get Christian, Dr. Kollesberger. Can I call you Christian? Is that okay? It's just shorter.
That's okay,
Christian,
Dr. Kapoor.
Thank you, Christian. What are your thoughts on that? Do you think is there any patient that, aside from bleeding or pain, that would have a nephrectomy de novo when they have their kidney removed de novo when they come in with metastatic kidney cancer? Would you agree with Dr. Miller? Do you think that's pretty standard now?
No, I agree with most of what has been said. I think one group of patients where I would still favor, two groups of patients where I would still favor an upfront nephrectomy is the one you just mentioned. Patients who have a lot of symptoms from the primary tumor, bleeding or something like that, where you really want to get that out of the way to make the patient feel better and to be able to safely deliver subsequent treatment. And then patients where you potentially have a chance to simply watch the patient after the kidney is gone. That's a relatively small group of patients, but we see them on a regular basis, and those are patients who have a kind of a large kidney tumor and very little outside the kidney, where you think, well, if we take the kidney out, maybe we can watch patients. And the reason for that is that we know that the behavior of kidney cancer can vary greatly from patient to patient. In other cancer types, the behavior is often relatively uniform, which means the tumor grows at a certain pace, etc. Whereas in kidney cancer, it can really be all over the place. And there is a group of patients where the kidney cancer, even if it's metastasized, grows very, very slowly, or not at all for a while. And those are patients which we can safely watch, and they may not need any other treatment for quite a while. So I think that is a group where I would still consider that. And then I agree with Dr. Miller. If patients go on systemic therapy, on immunotherapy or immunotherapy combinations, and the tumor stabilizes or shrinks, and they have a very good response, then I think it is a good discussion to have at some point to say, should the kidney tumor come out or not.
Wonderful. I 100% agree with you, Christian, which is, as you and I both know, is quite rare to agree. But on this one, it's very nice. And I think we're going to go to Dr. Lalani to talk about what the standard of care is. I know it's these words it gets a bit complicated for patients. And how would you approach a patient now? Say a patient comes into your office and you want to have a talk about immuno-oncology with tyrosine kinase inhibitor or dual IO therapy with nivolumab, ipilimumab versus pembrolizumab, axitinib. How do you approach that? Say, pretend I'm a patient, just an older patient, and how would you approach that?
Well, you never age, and so it's hard for me to treat you as older. But I think what you've heard already is that we would generally have a conversation about the IMDC risk groups, because that is helpful. We've talked about that. You've heard from Dr. Kommensberger and Dr. Miller about, does the patient still have their primary kidney in situ or present, or is this someone who has come after many years of a surgery and then had the disease kind of come back, unfortunately? And so having the kidney in situ or not, I think, is the next point for me that I think about. But if we walk past those two, then I think the short answer is the historic oral pill therapy I think has been beat out by using new novel agents. There's, for example, you've mentioned nivolumab and ipilimumab. This is essentially 2 IV treatments for a short time, effectively ramping up your immune system to fight cancer. And that's really restricted in Canada to patients who have at least 1 IMDC risk score, so essentially intermediate risk or more. Then for any risk group, there are some other options that will hopefully become more publicly available throughout the country, but there are some programs for this. This is using 1 IV treatment and 1 oral pill treatment. The IV, again, to try and ramp up the immune system, and the oral pill building on what we used to use, essentially strangling the blood supply, or what we call angiogenesis type targeted therapy. We do those two together, so let's say an oral pill every day or twice a day, and then an IV treatment once every 3 weeks. That type of approach can also be used, and that's kind of more routinely available across the risk groups. Dr. Kapoor, you've hit on a really nuanced discussion we have, and I'm sure all of us have it slightly differently, but I think the IMDC risk group is important to think about. I think being able to talk about all the available options with patients is helpful. I think all of us here agree we're relatively unbiased to the treatments. We want to give the right patient the right treatment at the right time. But these are both available. There's no I think patients want to hear, is there a comparison between these, and we don't have that available. So these are all good options to have in our toolbox. And there are some slight differences. What specific mechanisms are each of them doing? Are they using 2 different types? or kind of a pure IV immunotherapy regimen. So those are slight differences, but I think the big thing we want to take away is a patient suitable to receive immunotherapy? And I think that at that point is really important. Can the patient understand the side effects? Do they have any issues that might preclude immunotherapy? And I think we're starting to restrict those a lot, but we want to know if folks have histories of, colitis, Crohn's disease, other rheumatoid arthritis that are really active or needing systemic therapy, and we can all kind of piece out how important each of those are. But those are the kind of things a physician may ask a patient. But I think for most folks, they are eligible to get immunotherapy. And when they hear about it, I think they're quite excited. It's very easy to Google immunotherapy right now, and they're quite keen. So we try and find the best treatment tailored for the right patient.
Wonderful. That's a great summary on how to approach that. I think we also want to talk about some clinical trials. And so we did talk about the role for nephrectomy versus not having a nephrectomy in patients when they come up front with their metastatic kidney cancer. You have a clinical trial, Dr. Lalani, and I think we'd like to hear a bit more about that. And that's an option for patients who have their kidney still in when they present with metastatic kidney cancer.
Oh, I'm happy to share that. And I think basically the trial is trying to understand for folks that show up with a stage 4 kidney cancer that has spread, but the kidney is still present in the patient's body. What can we do? I think that you've all talked about historically, we thought about maybe taking out the primary kidney, and patients ask about that. They say, hey, I hear I have a 11 centimeter mass. It sounds big. Why don't we take it out? And I think as Dr. Miller mentioned, there's a lot of data suggesting that it's not so much yes or no to that question. It's that let's start with systemic therapy first. The clinical trial we're looking at is that if we start folks with this type of stage 4 disease, what we call de novo RCC, with immunotherapy, can we do better by doing something to the kidney mass? If it's not surgery, which could sometimes cause some delays to getting systemic treatment, can we try something else like radiation? The theory is that perhaps radiation in a very short 5-course treatment, relatively non-invasive, fairly limited side effects, perhaps that can provide some treatment to the kidney and then help leverage the immune response with the immunotherapy to further attack the disease better. We need to prove that. So we're conducting a trial called CytoShrink. It's mostly in Ontario right now. We're looking at onboarding other sites as well. Essentially, patients can get randomized 2/3, 1/3 to get immunotherapy plus radiation to the kidney, or immunotherapy alone. Still, all patients get the gold standard of immunotherapy, so they're very rest assured about that. And it's a question we need to ask to show if we can do better for these patients. And hopefully, we'll learn more as we get more patients on trial. And Dr. Poor, we thank you for your support, as well as you're an integral member of this trial. But I think it just takes a multidisciplinary team to lead this type of effort.
I think it's a great opportunity for patients, and radiation has been felt not to be an option for kidney cancer patients only, I guess, 10, 15 years ago. But in the last 5, 10 years, we've shown that patients can respond to radiation to their primary cancer or to other areas of metastases. And we call that SBRT or metastatectomies. And maybe we'll get Dr. Miller to talk a little bit about that. Dr. Miller, I'm not sure, McGill, I'm sure you guys are on the cutting edge. What's your thought about SBRT as an option for treating metastatic kidney cancer to the metastatic sites?
So I think SBRT to isolated metastases is becoming a standard for a lot of cancers, including kidney. But I think more importantly is trials like the one Dr. Lalani just described. I think we really need to figure out how to combine local treatment better with systemic treatment. In particular, there's this thing called the abscopal effect, which has been described first in melanoma of an apparent stimulation of the immune system by combining radiation therapy and an immune therapy beyond what you would have gotten with the immune therapy alone. And I think that's something that we like to hope for and haven't been able to prove how often it really occurs, but trials like the one you just heard may help define that. I think, again, local therapies in the era of immune therapy need to be re-examined. The randomized trial I talked about showed that nephrectomy plus Sutent was not any better than starting Sutent alone. But Sutent is a very different treatment, and as was mentioned, has fallen out of favor based on clear clinical trials that show the new combinations are better.
Yeah, that Carmina trial has been, as you quote, again, a very landmark trial. Again, I would say there's a lot of faults in that trial, as there are with many trials. Again, they had more poor prognosis patients than that, almost 40% poor prognosis in that trial. They didn't reach the recruitment for that trial, so they didn't get all the numbers they wanted to in that trial. And they had a selection bias in patients who were candidates for nephrectomy were not really put into that trial. So within the limits of all those criticisms of the trial, it does look like getting upfront systemic therapy is probably a good idea. And then also clinical trials such as Dr. Lalande's SOUDERSPRING trial is a great option as well. I would like to ask Dr. Kolstenberger about other trials. Dr. Kolstenberger, as you know, is a leader in clinical trials across the country and around the world. And he has his own trial looking at immunotherapy. But Dr. Kolstenberger, I'll give you the floor to talk about clinical trials in general and any particular trial you want to talk about.
Thanks, Anil. Yeah, so as we already heard, I mean, clinical trials are an important tool in what we do for a number of reasons. Number one, because without clinical trials, there is no progress. And I think that is something which is extremely important. And irrespective whether it's a blood pressure pill or a heart medication or whatever, or a cancer drug, all these drugs have to go through clinical trials. And that is really the testing where we make sure that A, the drug is safe, and B, the drug is actually valuable to our patients. So without these clinical trials, there is no progress. And there are different types of clinical trials, and if you want to do that, we can go into that in more detail. But there is generally three types: phase 1, phase 2, and phase 3, and they're called because there are three different phases of testing. The phase 1 trials are the early trials where we really just want to make sure that we have the right dose, and usually these trials allow different tumor types, so we can get a little bit of a feel in which tumor types the new drug may be beneficial. And those are small trials, 20 to 50 patients maybe, and usually very few centers participate in a trial like this. And once you've done that, and you know in what direction you want to take your drug, you can do phase 2 trials. And phase 2 trials come in very different ways, but the bottom line for a phase 2 trial is you want to try your drug in a specific patient population. So for example, only in patients with breast cancer, or only in patients with colon cancer, with bowel cancer, because you want to get a feel of how active the drug is there. And when you have that result, and these are trials which have somewhere between 30 and 250 participants, then you can go and you can look at the results, and you can say, well, based on everything we know about this disease and this particular situation, this looks promising or it does not. And if it does look promising, then you can take it into the third phase in so-called phase 3 trials. And those are large trials, hundreds of patients participate in these trials. And it's simply a head-to-head comparison between the existing standard treatment and the new treatment option. And the objective is obviously you want to know whether the new treatment option is better than the existing standard therapy. And as you all know, and I would like to quickly explain that because I think it is important and something which is always of concern for patients. The standard arm is really chosen based on what is the standard of treatment at the time the trial is designed. And in most cases, that will be an active drug therapy. In some situations, it could be what we call placebo or observation alone if the existing standard is observation. The important thing about a phase 3 trial is that it's what we call randomized. And randomization is a process which makes sure that you actually compare apples with apples and not apples with oranges. And what I mean by that is we know that there's a number of factors which impact how a patient is going to do with their kidney cancer. Just to give a simple example, somebody who is running around all day and can work out will probably do better than a patient who cannot do that and sits on the couch all day. So we know a number of factors which impact that, and we need to account for that. But there's also a number of factors which we may not know and still impact outcome. So in order to make sure that both groups are balanced in terms of these factors, we do this process called randomization, which means that patients get randomly allocated to A or B. That assures that the trial is done under the same conditions and make sure that if there's a difference in outcome, that the outcome must be attributed to the treatment. So that's important to know, because only if we have a properly done trial, we can really say with certainty that yes, the new treatment is better than the old treatment. I think the other important thing patients need to know about clinical trials is that the participation is entirely voluntary, and that patients can withdraw their participation at any time. And the most important paradigm for investigators like you and me and Dr. Lalani and Dr. Miller is that we don't want to expose patients to any increased risk of harm. So we will do everything to keep patients safe. Now, that's kind of the background of clinical trials, and clinical trials is important to make sure that we find new treatment options. For me personally, however, clinical trials for me are an important tool to offer my patients additional options they otherwise wouldn't have. Keep in mind, all these drugs we have, if you participate in a trial, you may get an additional option at a time where we don't have unlimited options for our patients. So if you participate in a clinical trial, that means you can potentially get exposed to something which may not be available, but may be a valuable drug. So for me, that's really the main reason. And I always tell my patients that I wouldn't offer them a clinical trial if I wasn't convinced that it was a good option for them. And I think that's important to understand. And that's why I think it is important for patients to ask questions about that, because it could potentially offer them something they otherwise don't have access to. And there's a variety of trials out there, and we are just at the beginning of another wave of new clinical trials. There's a number of new drugs out there which are moving into clinical trials right now, which look very interesting based on the results we have so far. And that is something our patients can use.
That's a great summary. Thank you for doing that. It's really breaking down the advantages of clinical trials and what they're all about. So I think it's wonderful. There's a new molecule coming out in the second line trial. Dr. Lalani, do you want to talk about that? That's going to be offered across Canada?
Sure, yeah. I mean, I think Dr. Komensberger has really set up how important trials are, and there's so many that are going on, and I echo the encouragement for patients to think about trials because of what they can offer. One such option is an agent that has some letters and numbers, but essentially it's a HIF-2 alpha antagonist. You know, very simply, we think that HIF-2 alpha has an important role in promoting some of the factors and the angiogenesis, kind of background that kidney cancer loves to grow. And we have lots of great pills in the past that have hit the receptors for some of these on certain cells, but then in the tumor cell, there's a process where something called HIF-2 alpha is very helpful for the cancer cell to grow. So if you have an inhibitor of that, something called a HIF-2 alpha antagonist or a HIF-2 alpha inhibitor, maybe you can further starve the kind of supply that the kidney cancer cell loves and do better than what we've done right now. And so there is a trial looking at patients who have already received immunotherapy, already received the historic VEGF targeted therapies or other oral pills, who could enter this trial to get this very novel agent, a HIF-2 alpha agent, or another kind of historic standard of care. So as Dr. Komensberger mentioned, a randomization, kind of a computer or a toss of a coin between this novel agent or a drug called everolimus, which has, still some activity for those folks who have tried all the other typical agents available. So I think that is it's a drug we're really looking forward to making a leap forward, as you've heard from the panel, that trials will help us move the needle forward. And so some of the history of that drug is that it was studied heavily by Dr. Bill Kaelin, and if you look him up, he was one of the 3 winners of the Nobel Prize, I guess now last year. And so this is a drug or a target that should be very promising. So I would say that while the patients here are hearing about immunotherapies, they probably have heard about oral pills before. There are options, even if you have treated your cancer with these immunotherapy and oral pills, and you're looking for something else. A trial like this may be out there for you, and I'd really encourage you to ask your cancer center, your doctor, about this type of option for you.
Wonderful, thank you. So that's an option for what's called a second line therapy. We're going to just reiterate and repeat what's available in first line. So the options for drugs in first line therapy as really the standard for intermediate and poor risk is the drug called belimumab with nivolumab. And this backbone therapy, many patients are being offered, and there's about a 10% possibility of a complete response. I think that's an incredible number. In the past, when I'm the oldest of most of the panel here, maybe Dr. Miller is older, but back in the day, we were giving interferon and some of the other drugs, and then we were giving sunitinib and pazopanib, and these had a low response rate or a complete response rate of only about 2%. And now we have the option of this IO backbone with which has been offered for patients with up to a 10% complete response rate. That's really amazing results, and so that's really wonderful for patients. And Christian, wasn't there some recent study out of ESMO suggesting that is still a good option for patients out long term?
You mean the nivolumab ipilimumab option?
Is that not what I think I said that? Did I misspeak?
No. Yeah, I mean, the current regimens we use, the trial results are still continue to be updated on a regular basis, because as you can imagine, we're interested in getting access to these things as early as possible. So they come on the market and they may even be approved, but we still have to watch them, what these regimens, how they perform long term and not just in the short term. And that's really something which should go into a discussion with a patient about treatment goals. What are we trying to achieve, and what is the individual situation of the patient, and how can we best serve that individual situation with the optimal regimen? And just at the 2 biggest meetings for oncologists in the world, the meeting of the American Society of Oncology and the European Society of Oncology, a lot of these trials were updated. And the trial you referred to was updated, and the patients on this trial have now been watched for more than 4 years, which is a long time on these trials. And it appears that a lot of the patients who were treated with that combination of 2 immunotherapy agents and had a response, which means the tumor has shrunk while on the treatment, that response seems very stable, and a large number of these patients continues to respond without any further treatment, even after that long observation period. And I think that is something important, because that's, at least in my experience, something patients really desire, to have kind of a long-lasting response. And what was even more interesting was that a large portion of these patients had stopped their immunotherapy treatment and continued to be in response and did not need any other subsequent treatment. Now, we don't have that long follow-up yet for the other type of combination, the immunotherapy plus the oral pills. And I think that is something which we need to wait for. These regimens have other benefits. For example, that the initial control over the tumor happens in a larger portion of patients, and less patients have treatment failure with these regimens, which can be very beneficial for certain patients we see. So it is really a toss-up between this short-term benefit, long-term benefit, and that is something which needs to go into a discussion with patients and talk about the situation and the treatment goals, and then make a decision which regimens may be the best for an individual patient.
Wonderful. So that is exciting though for patients, that if you are on this Ipi/Nivo combination, out 4 years or longer, you can have an amazing response and durable response, even if you stop the therapy. So that's exciting. And you talked about pembrolizumab with axitinib, which some patients are on as well, and they've also had a good response. There's a third option coming out for patients as well, so we'll have a third choice. Dr. Miller, do you want to speak to that, the cabozantinib-nivolumab
Right.
combination?
I think that's a very exciting combination. We have, unfortunately, the earliest results on that trial, which makes it more difficult to compare with the other trials. But there was an outstanding response rate. It appears to, very few patients have primary refractory disease, so almost every patient gets some benefit. Unfortunately, just as Christian was saying, we don't know the long-term duration of response. I think that the key feature that we know from the Ipi/Nivo trial, in part because we have long-term follow-up, is that there is a solid duration of response. It looks like 30% of people may ultimately have long-term survival without treatment, without symptoms of disease, and might even be cured. And that's 3 times the complete response rate that's reported. So I think that's very exciting for Ipi/Nivo. On the other hand, we would love to have the more rapid response, especially in patients who have very rapidly progressive disease, and the lower percentage of primary refractory patients that we see with both the trials of immune therapy plus targeted therapy, but especially preliminarily looks good with cabozantinib-nivolumab. And I should mention that the idea of combining the best of both worlds is out there. So there is a trial that may actually be ending accrual soon of Ipi/Nivo plus cabozantinib compared to Ipi/Nivo. And preliminary results, which honestly I initially found a little surprising, is the combination of the 3 drugs does appear to be reasonably well tolerated. So you can get the drugs in, and now we have to see if that may bring us the best of both worlds.
Yeah, I think from a patient perspective, you have all these amazing agents. If you put them all together, that would be fantastic. But if you're not able to get out of bed, then that's not really so fantastic from a quality of life point of view. So Ipi/Nivo plus Cabo plus everything else that's available, we just have to make sure that it's not too toxic for patients. And so we look forward to that data, combining everything together and seeing how the outcomes are. And I'm sure the outcomes will be great as long as the toxicities or the lifestyle can be manageable for patients. Quality of life is very important for our patients, and that's really one of the key factors. I'm going to switch gears a little bit.
You can't respond to a treatment that you're not able to get because you don't tolerate it. So, you can combine every single chemotherapy drug, and if people were able to take all that at the same time, their tumors might shrink great, but they're not able in many cases. So I think this is the core of the issue here. Although, as I say, so far, preliminary data, patients are able to tolerate the triple regimen, and so I'm optimistic.
That's wonderful news, Dr. Miller. I'm going to switch gears a little bit. We talked about metastatic patients, but this session is to talk a little bit about all of kidney cancer. So we're going to talk a little bit about localized cancer, then ask Dr. Lalani about adjuvant therapy and what that means. But for localized cancer, the still standard has evolved that if you have a tumor of your kidney, we're still trying to do for localized non-metastatic cancer a partial nephrectomy, and that's still the standard of care that's emerged. Dr. Fanelli is going to talk a little bit about that later on today. But if there is a tumor of the kidney that's amenable or possible to take out the tumor and save the kidney, that's really the best thing for long-term renal function and cardiovascular health, to try and prevent any renal disease, keep your kidneys healthy, keep your renal function really good. Trying to do a partial nephrectomy is very important. And it's important to also say that sometimes it's not possible. If the tumor is very central, even a small tumor, or if the tumor is too large, then we may not be able to do a partial nephrectomy, and then a radical nephrectomy or removing the entire kidney is not a wrong decision. One thing that Kidney Cancer Canada has advocated is a second opinion, and we all support that as clinicians, is that if you're not comfortable with the explanation or you do want some validation of the opinion you've gotten, getting a second opinion before undergoing any surgery is very, very reasonable. We do also have some other options that are available for patients with small tumors. One's called RFA, or radiofrequency ablation, where you can put a probe into the tumor and burn it off. That's a day surgery procedure now and may prevent the need for a major operation. The other option now is actually SBRT, or radiotherapy. You can actually radiate these large tumors with good control. And we also have a clinical trial going on in Ontario looking at SBRT versus RFA for small masses. So that may be an option as well. That's offered through a trial. But from a surgical point of view, really the standard of care is still a partial nephrectomy if it's possible for localized cancer. Just a repeat of what the staging is, if it's a small tumor less than 7 centimeters, it's called a stage 1 cancer, or T1A or T1B. If it's a tumor that's over 7 centimeters, then that's a T2A, T2B. A T3 tumor is if it's a tumor that's into the vein surrounding the kidney, and that's a more advanced tumor, but still curable. And T4 is when the tumor is into the tissues around the kidney. And so as surgeons, we like to get all the cancer out, and then we stage it afterwards with the pathologist to get an answer as to what stage it's in. And for T3 or T4, it's very hard to do a partial nephrectomy on that because the tumors are usually so large, requires an operation. And we can talk briefly if there's any questions about robotics versus laparoscopic versus an open surgery. We like to do minimally invasive surgery with laparoscopic or robotic surgery if possible. But really the main thing that clinicians want, as well as patients want, is the cancer out the safest way. And so that's also very important to consider as well when you're talking to your surgeon about getting the tumor out. Now, the cure rates are very high for T1A. If you take out a T1 tumor, your cure rates is 90–95% for these tumors less than 7 centimeters. So that's really wonderful, a high cure rate. And then for T2, we also have a high cure rate, 60 to 65 to 80% sometimes, depending on T2A versus T2B. But then when we get into T3, when the cancers are into the vein or the sinus of the kidney, the cure rate's about 50–50, and that's where we have lots of areas of research going on that all the panelists have been involved in what's called adjuvant trials. And I'm going to get Dr. Lalani to explain what adjuvant therapy means.
Yeah, no, thanks, Anil. So, really, we had previously talked about what happens if it's a spread situation, but as Dr. Kapoor has mentioned, the localized situation, there's some questions we've asked in the past, and some patients may have been enrolled on these trials, but if a patient has a localized kidney cancer removed, can we give them treatment right after a surgical procedure? So essentially adjuvant therapy after the definitive curative therapy has been done. And there's been lots of trials looking at drugs like sunitinib, pazopanib, cousin medications, these oral targeted therapies. And these are really important questions to ask, because if we could do better to help folks live longer or help delay the chance of the disease coming back, then clearly we would want to offer that as a standard to our patients. So for the oral pills, I think just a quick summary is that these have been done across the globe with hundreds and thousands of patients really in different countries. And when you put all of this together, I think it really shows that these oral pills don't have that benefit for patients who have had their surgery and their kidney cancer removed. So generally, what's called adjuvant therapy for these oral targeted therapies generally is really not the standard of care for most patients. And that's really on the basis of not helping the patient live longer, or really meaningfully for most folks, delaying the chance of the disease coming back beyond just watching very closely, or in some of these trials, a placebo. So for most people who have this type of surgery or any of their other all cancer essentially removed, then there's no standard to give an oral pill after. But as you've heard, immunotherapy is really the standard of care for a spread setting. So the question becomes, why don't we try and do that after surgery? And so there's lots of trials for that, and some patients may have been enrolled on those trials. Drugs like IV treatment with atezolizumab or pembrolizumab, these trials were done. We're really pending to see the data and to get really the truth as to whether that helps folks live better or longer without the disease coming back. There's still some trials in Canada that are open for this type of patient who's had a surgery already. One is a Checkmate 914 trial, essentially looking at nivolumab plus ipilimumab or another arm of nivolumab alone, essentially 1 or 2 IV immunotherapies after your surgery. Is that better than, in this situation, a placebo IV treatment? I believe there are some centers in Canada that may be available. There's also a trial, and really a shout out to really everyone here, but also specifically people like Neil, Danny Hang in Calgary. I know Dr. Finelli also participates in this trial, but the Prosper trial, which Neil, I think you've been really a fearless leader for, which is patients who are due to have a surgery, can they have potentially some immunotherapy pre and post surgery, kind of a neoadjuvant and adjuvant approach? Does that kind of approach help delay the chance of the disease coming back or improving the so-called cure rate? And so that trial is the Prosper trial, which many countries are participating in, is still open. And we really encourage patients to consider that because, as mentioned, it's a randomization. There's a, kind of a coin toss between getting your standard surgery, the gold standard, and being observed, or getting immunotherapy surgery and then immunotherapy after in a random way. And so that is, I think, really the state of the union. And patients can rightfully ask to say, what if that becomes standard? Certainly we would want to share that information. I think patients will hear about that. And we would advocate that if these trials prove to help patients in that setting, then certainly we would share that information. Right now, we don't have data to prove that, but hopefully we will soon.
Wonderful, excellent. So yeah, I think it's important to get involved in a clinical trial because currently we don't have any standard after these surgeries, and other than close vigilance. But I think we have about 10 minutes left. I want to ask some questions or take the questions from the audience. I know that probably lots of questions. I can tell there are because Mona is signed on. So Mona, are there any questions out there for the panelists, or you're on silent?
Okay, I'll just jump in, and I just want to thank all of you very much for participating and sharing your valuable time with us. This has been most informative. You've actually touched on several of the questions that we already have had, one of them being triplicates, because that seems to be an up-and-coming treatment option. Dr. Wilson Miller touched on that a little bit with the 3 therapies together. But I'll let you know that one of the biggest concerns that we are hearing from our patient community is they're grateful for all the first and second line therapies that are coming, and they are proving to be really tremendous. But those that have gone on the first and second line, especially the new ones, they are most concerned about what is in store for them as third and fourth and fifth lines. And I realize that there isn't a lot of data there with the new therapies, but maybe you can ease their mind a little bit or offer some information on what options might be available to that community.
Yeah, so maybe I can answer that briefly. There are a lot of phase 1 trials going on, and Christian talked about the difference between phase 1 and phase 2. There are literally dozens of receptors on T cells that can turn them on and off. And so far, we've only targeted 2 of them successfully in the clinic. There are trials with a whole gamut of antibodies to other receptors, either to turn them on or off, with or without the checkpoint inhibitors that are already in the clinic. There are equally many trials trying to change the tumor microenvironment by targeting HIF2 or TGF-beta or other signaling pathways. So I think there are a lot of things coming. We currently have several trials that would be appropriate in that setting, and I'm sure across the country there are a number of such trials. So I think I would be optimistic that as long as we can keep our patients in second, third, and fourth line healthy enough to be eligible for a trial, there's something there.
So Christian, what are your thoughts on that? If you have a patient that's progressed after, say, first line, you put them on ipi/nivo, second line is cabozantinib or axitinib, and then they progress at third, what are your options in the current day? What would you offer your patient now?
Yeah, I think in the current day, it's relatively simple to explain. So if you start with an immunotherapy combination, nivolumab and ipilimumab, there are two other lines of therapy, at least in BC, out there you can have. If you start on one of the old treatments with pills, there is also a second and a third line option out there. And if you currently start on the immunotherapy plus the pills combination, there is at least one other option out there. I think it's important to understand how the process works, because I think there's a lot of misunderstanding out there about that. In Canada, in order to get treatment options paid for, there needs to be some kind of evidence that it is helpful. And you can imagine whenever the first line option changes, that basically kind of confuses the whole scene after that, because you change the entry point, so everything else changes. At the present time, I think we have for almost all of our patients several options, but we need to be diligent and continue to develop that evidence for upcoming options, which we've discussed previously, which are currently under development, the triplets and the other doublets. So we need to continue to do these clinical trials and to do all this research to make sure that when these new regimens come into the market and into our toolbox, that we are prepared to also present our regulatory people with the evidence that there is something after that.
Wonderful. Thanks,
Thank you.
thanks, Christian. Thanks, Wilson. Mona, is there any other questions you have?
Yep.
All right, so a question from Russell. He's trying to understand if an old patient can now re-challenge with combinations of TKI and immunotherapy, cabo plus ipi/nivo. New trials and tailored drug treatment development may give increased hope to patient now on line 3 or 4 looking for 5, 6, 7. So he's clarified it and said, if you failed on a single agent TKI or immuno, then is it reasonable to re-challenge as a combo like cabo and nivo?
I'll let Dr. Lalani answer that. I mean, ideally, we would love that, but he's going to clarify the reality.
Yeah, and I'll keep that in a nice punchline for a really great question that has. So first of all, thanks for that question. As you've heard from Dr. Kommensberger, some of how we offer treatments is in the setting in which they are studied. So as you've heard for Nivo Cabo now, Nivo Ipi, Pembro Axi, generally these have been studied in large amounts of folks in phase 3 trials as your first treatment. So while I personally would love to be able to avail of some of these after, and there are some small institutional level data across the world trying to study this, largely those combinations that were mentioned are for your first treatment. And I think the COSMIC trial, which Dr. Miller mentioned, the Nivo, Ipi, and Cabo is also being studied and will likely be having a label attached to it as your first treatment. I think, Christina, if I'm understanding, it sounds like a lot of folks are asking, generally, what can I do after I've used treatments, whether it's trials or recycling? And I think what I would say is that for patients who have used one targeted therapy, and assuming it's within the first 3 lines of treatments or 3 options you could use, we still generally would try another targeted therapy after. Recycling or reusing of immunotherapy is something that has been studied in smaller studies, not really found for most folks to help them, although the one caveat being a trial that Dr. Kommensberger really, I think, was a founding force behind was if you've used nivolumab and ipilimumab and you're on the nivolumab portion, can you receive ipilimumab again to try and reinvigorate the immune system? And that is a trial ongoing. what I would say for all patients who have received immunotherapy or oral pills is please ask about clinical trials. I did mention the HIF-2 alpha drug, which I think is going to have a lot of trial centers across Canada. That is a third or fourth line option. There is another trial called CONTACT-3, which is coming, looking at IV and oral pill or an oral pill as a trial. Essentially, your physician will work to try and find a treatment that you have not already used or has been not already used in your cancer and has a reasonable chance of providing some anti-cancer therapy. So whether that's a phase 3 trial, a smaller phase 1 or phase 2, as Dr. Miller mentioned, there are options so long as patients are largely well to try and seek referrals for clinical trials. So I would say that if the standard has been used, Christine, if we can get the message out to patients to ask about trials, to ask about early, physicians are always trying to turn over every rock to find options for patients, especially who are well enough to get, as was asked, that third, fourth, fifth line treatment. It's not always the case, but if it is, we need to do our best for those patients.
Thank you. I appreciate that answer. Mona, do you have another question?
Yes, I've got two more. So the next one is from Joanne. Does combo of axitinib and pembrolizumab kill cancer stem cells?
We'll get Dr. Miller to answer that question.
Yeah, so that's a great question. We hope that it does, but we really have very poor tools of determining the response of cancer stem cells to a variety of treatments. I can maybe make an inference from the most advanced trial, which is the Ipi-Nivo trial, has the longest follow-up. The plateau we seem to be seeing after 4 years, if it holds, suggests that the cancer stem cells have been wiped out along with other cells. It's too early to say whether Pembro-Axi will do the same.
Okay,
Thank
and
you.
Mona, do you want one more? Thank you.
Yes.
Thank you, Dr. Miller.
It's a question from Eve. If you are proven to be IO non-responder on one IO combo, is it a given you would not be a responder on another combo, including a TKI IO combo?
Dr.
So that's-
Goldenberger?
Oh, go ahead.
I think we'll get Christian answer that one, Dr. Miller.
I
That's
think at the present time, to be absolutely honest, we don't know that yet. These trials are currently underway, and we are looking at that. In general, I think what we've seen so far is that from the data we have is that it is the likelihood that if you fail one immunotherapy regimen, that you respond to the next is probably not that high. But at the end of the day, we need to really do the trials to see whether there is benefit or not. What we do know is that if you failed a immunotherapy combination such as nivolumab and ipilimumab, that you still have a good chance to respond to a oral drug like a TKI, like sunitinib, cabozantinib, axitinib, and these drugs. And the question of sequencing immunotherapy agent, that remains to be seen. There is a large number of trials underway with novel immunotherapy agents which tackle and interact with the immune system differently than the drugs we are currently having. And it may well be that in the future, one of these or several of these drugs which interact with the immune system in a different way may be active one after the other. I think that remains to be seen.
I'd like to
Wonderful.
take just a
Well,
moment. Welcome, Dr.
Sorry,
Finelli.
Christine, you want me to, I think I'm happy to finish the moderation, thanks. So is there any other questions there, Mona, at all, or? No, okay, well, I think we're on time for 2:05, so I want to thank everybody for your participation in this, and Dr. Goldenberger, Dr. Lalani, and Dr. Miller. It was a great interactive session, and I really appreciate all of your insightful answers. Thanks so much. Christine, it's all yours.
Thank you very much. Thank you.